And this is Dr. Hall. Dr. Hall does interventional pain management, EMG work. He's physical medicine rehab trained, and he joined us a little over a year ago, I think. So he's here also. So that's a rendering of what you'll see in likely a little over a year if the winter is kind to us. And all that construction out there, it's one of the 4 lots there is where we'll be. So we'll have office, imaging, therapy, and we'll renting out some space. Sports performance will be moving from here to there also. And we'll have surgery on the 2nd floor, outpatient surgery. So that's our new office, is it? Our office. And that's where it's located. So the hospital's here. Okay. There's Oleo. And then we're actually in this corner. The hospital owns this corner. We have 2 lots that we need to sell. So if anybody wants to buy and develop some real estate, we have something available. So we're here to talk about hip and knee replacement. So the main reason we do hip and knee replacement is arthritis. So arthritis is a degenerative condition that results in pain, swelling, and limited motion. I don't think people understand it real well. The way I explain it is it's osteoarthritis is basically damage to the cartilage. So the cartilage is what coats our bones. It's the same thing you'd seen in a chicken leg. So when it's healthy, like a chicken that's slaughtered, it's a smooth surface, very low friction. There's some on each side of the joint. And if you look at it histologically, that's what it looks like, nice smooth surface. It's got lots of function, and it actually fills with fluid. When you put weight down, the fluid rushes out of it. It works kind of a cushion and a low friction. Arthritis, the surface breaks down, and it looks like this microscopically, and then eventually basically wears down until there's nothing except bone touching bone. So causes, it's probably injury and genetics. Body weight has some factors with it. But there's 90-year-old runners that never have any arthritis, and there's 30-year-olds that aren't that active, that have horrible arthritis, and they're not heavy and had no injuries. So there's other components with this. So if there's some deformity, if there's an old injury like an ACL injury, people generally get arthritis with these things. So here's just a drawing. So a healthy knee has 2 meniscus, articular surface, and then basically the arthritis wears down the cartilage and we get exposed bone. So this is arthroscopic photos. So here's a smooth surface. Here's what happens with arthritis. The pink stuff is the bone. The white stuff is the remaining cartilage. So those are knee arthroscopy photos. Here's what x-rays look like. So we have the femur above, the tibia below, kneecap in the front, and the spaces are pretty good. So we have a little arthritis there, but the cartilage space is good. So we do standing x-rays to determine this. And all of a sudden we see the space is narrowing, just a wafer space. That's fairly advanced arthritis. One side of the knee, medial compartment, which is common. And then it can get worse. So now we have bone touching, there's some bone changes, it's flattening. And this has gone too far, right? So now we've worn through the bone. So this is actually on the outside of the knee, but there's a very big deformity here because after the cartilage wore out, then the bone started scraping the bone wore down and created a much more difficult problem to deal with. So I divide treatment into 3 stages, the slide. So I tell people that stage 1 is everything that you can do as a patient. So that would be Tylenol, Aleve, Advil, ice, heat, rest, exercise, a wrap, modifying your activities around your disease. So that works pretty well when the arthritis isn't too bad. But as it gets worse, that won't be enough. So in the knee, injections work well. Cortisone is probably the mainstay of injections we use. It's very similar to the anti-inflammatory pills, except it works only in the knee. It's safer if you have to do it continually, because if you take anti-inflammatories, you can get ulcers, kidney damage, other problems. Cortisone doesn't have those risks as long as it isn't given too often. Viscosupplementation is an alternative. Some of the insurance companies are no longer covering it. It's a gel, different mechanism of action, so it does work sometimes better than cortisone, most of the time not necessarily. But it is a different mechanism, so there's a small number of people who will do much better with one than the other. And then we have surgery. So there's a photo of a knee replacement. So a knee replacement is some of a misnomer. It's actually a resurfacing of the knee. What happens is a very small amount of bone and remaining cartilage is removed from the bones and it's resurfaced with metal and plastic. And so this is the femur. So this is about 8 millimeters thick, so not very thick. And then there's a thin tibial piece of metal, and then the plastic of varying thickness can be placed. So this is what an x-ray looks like. So this is a knee replacement. So this knee has pretty bad arthritis. You can see the femur subluxing off. Bone is touching. There's indentation. So that knee will need to be replaced. This one has been replaced. So you can see this one's bowed. This one's straight. So a small amount of bone was cut here, replaced with metal, and then you can see the plastic distances in between. And then the kneecap was resurfaced also. So that's what an x-ray looks like after knee replacement. So there are new technology. That's kind of the title of the talk. So one of the things that has come out is it's been tried, I think ever since I've been in practice, people have been looking at ways to not use cement in the knee. In the hip, we don't use cement anymore. Haven't really much for many years, except in isolated circumstances. But in the knee replacement, people have not historically been able to achieve the same survival of the implant without cement. Stryker has very good data at 2 years. The 5-year data is apparently very good. It's going to be released, I think, at Academy in February, or I guess March. But from what I understand, the 2-year data is great. It's doing as well as cement. And in the hip, when we moved from cement, away from cement, a number of things got better. So we do think today in a hip, if we do an uncemented, these special metal implants, sockets, they may last forever. You can change the liner, but the binding to the body may be very, very long-term, much more long-term. So total knee replacements that were done 20 years ago have an 83% all-reason survival today. We've had improved plastic and some improved things we'll talk about here in a minute, which may be driving that number up. It'll take a long time to tell. Getting away from cement may be a further improvement, particularly on the tibial side. So navigation. So we actually brought one. So historically, I think we'll go over here. So historically, the way we do knee replacement is we either put a jig outside the bone, or we drill a hole in the bone and stick a rod inside it, and then we'd have a cutting guide, which looks a little bit like this without the fancy stuff. But basically, you would kind of attach, put some pins in, and you cut the bone. And there's about a 3-degree error each direction. So if one is 3 degrees this way, the other one's 3 degrees the other way, you balance pretty well. But if both are 3 degrees the wrong way, you can end up with a knee that isn't lined up very well, and the implants may not last as long. So this is navigation. This is what we're doing currently. And so what happens here, this is just a bone model, but we pin this on the bone. So this is all within the incision. So there's no extra incisions or anything with this. They've already gone through some of the sequence. You basically lift the leg and wiggle around things, and you center where the hip rotation is, center where the center of the femur is. And then once you have that information, then I gotta get out of the way of the camera, you use this little device here that has, those are cameras, so there's multiple cameras there. And so you basically just capture some data on where the bone is, like this. Once you've done that, you go to the outside of the knee, do the same thing. And possible points. Well, doesn't like it. I need help. So what's happened is, it's okay, all right.
Oh, okay.
Oh, okay. So then what we do basically is you have a cutting jig. So we now know where the center of the hip is, the center of the knee is, and we can hook this device on, and it tells us the different angles we want. So it's already kind of preset for the right angles. The resection's a little aggressive, but we can determine and change angles like this or this in this plane. And then we basically, once we have this where we want, we put a couple pins in here and make the bone cut. So here we're reduced that error substantially, plus we didn't drill holes inside the bone, so we don't have marrow problems or as much bleeding. And we do this, a very similar process on the tibia. It's more accurate, and then we're able to balance a knee better and get something individual to each person. It's very, very helpful if there's any deformity in the leg. So if there's ever previous surgery, a fracture, this bypasses that part of the anatomy. So that's navigation. We've put it in our workflow over the last year, and it's I think our patients are doing, our x-rays are better, we're getting more accurate, and patients are doing better. So that's one new technique. Another device I'm using is called Ortho Sensor. When we look at how people results are after knee replacement, if you ask someone, is your knee pain much better? The response rate is very high. It's probably 97% of people say that. But if you ask them if they're satisfied, the number drops to the 83, 85%. And there's maybe several reasons for that, but one of them is probably that total knees don't function exactly the same as a natural knee, and some of this may be ligament balance related. So there are several things that can help with that. And this device basically is something that's sterile in the operative field. There's a little computer screen on the side, and it gives us live pressures. So once we cut the bone, we put temporary implants in to kind of see how things fit and track. Normally we would kind of feel it with our hands, decide where things are tight or loose, and make adjustments based on that. That's pretty subjective, how it feels. So this is objective. This gives us a number. And there's data that shows that if you can get the pressures within 15 pounds of equal on the two sides of the knee, and no pressure more than 30 pounds, that satisfaction rate jumps. So people jump in the 90 some odd percent being happy. So we were using that on many of our patients. And then there's some other techniques that are out there that I don't have on here, but other ways to approach the same idea. Another thing, there's pain, I think, is something that people fear, particularly in the knee replacement world. Hip replacement isn't as painful. We use a tourniquet generally. We've all trained to do that. So a tourniquet squeezes on the thigh like a blood pressure cuff, except it's inflated to more pressure. So you're under anesthesia, you don't feel it, but that doesn't mean when you wake up you don't feel it, right? So we have a lot of people that have as much pain up here as they do where we operated. So there's this bipolar device that we've been using. We've been doing a lot of our knees without a tourniquet inflated, and there's several studies that show less pain, less swelling, more motion, and people are happier earlier because they're not recovering from a muscle injury from the tourniquet. The other thing, and I don't know if that's on here, is one of the benefits, I think, is if we have a tourniquet on for an hour doing an operation, there's no blood supply to the skin, there's no blood supply to the wound. Antibiotics aren't coming there, right? But if we don't use a tourniquet, the skin isn't hypoxic. It doesn't, the cells are still getting nourished. So I think we're going to have less wound problems, probably less hematoma, and hopefully less blood clot. So I had been doing this more selectively on people that were very heavy, and I was worried about skin, that kind of thing. But people did well with it, and I'm doing it on most patients now. So then we have partial knee replacement. So the knee has 3 compartments. We have the inside, the outside, and then the kneecap area. About 20 to 30% of patients have most of their disease in one compartment. And if the rest of the knee is good, you can make a pretty strong argument to not remove it. So partial knee replacement has done well. Patient satisfaction is higher. People are happier with partial than total knee replacements, although we may be doing a little bit better with the Ortho Sensor and some of the other things we're doing. It's a smaller operation, so there's less bleeding. There's data out of some institutions showing lower infection rate probably because you're doing less. And if it's well done, typically if it does fail, you can convert to a total knee relatively simply. So if a total knee fails, comes loose, you fracture around it, whatever, you have to remove it, then you have to remove more bone, use much larger implants, get fixation above and below, like in the shafts of the bone. Whereas with a partial knee replacement, if it fails, you can usually put a primary total knee on many times. So this is some x-rays. This is in Oxford. This is the one we're currently using. Does well. It has a small piece of metal on the tibia. There's a couple metal implants inside the plastic just so you can see it on x-ray, know where it is, because it isn't attached, it moves. Hip joint. So hip arthritis is also very prevalent, not quite as prevalent as knee arthritis, but I do almost as many hip replacements as knee replacements. Same type of pathology, the cartilage is damaged. So here you see some arthritis, some spurs, some joint space narrowing, bone is getting close to touch. This patient also has impingement. There's a bump on the femur that kind of prevents it from moving freely. Same type of symptoms, pain, stiffness. Typically people have trouble getting in and out of a car, can't reach their foot because of loss of motion. Pain is usually in the groin, it can be down to the knee. It's not usually back here. This is usually back problems. So we have the same options. Steroid injections are much more difficult. The hip joint isn't accessible. You can't feel it. You need x-ray dye to get into the joint accurately. Whereas a knee joint injection is something very simple we can do in the office. So we don't do as many, but they still are helpful. But we have the same options. We live with it, start to get too bad, maybe we do cortisone, then we look at hip replacement. So this is a hip replacement. So what we basically do is remove the top of the femur. We have a navigation system for that also to help us align mostly the socket. And then the bone is hollow, and we get the right size stem, adjust the cup position. There's some plastic here, just like there is in a knee replacement. Here's a drawing. So there's metal inside the bone, a ball, usually ceramic today, plastic lining, something in metal. And these cups, again, are almost like a three-dimensional screen. Bone can grow into them. So I've been doing anterior replacement for probably well over a decade. I trained to do a posterior approach. Posterior approach is an incision on the side. That's probably what most people have heard of. The anterior incision, generally in the front here, either a transverse or a vertical incision. Hip is closer to the front than the back. There's a number of studies show quicker recovery, quicker pain relief, a little less chance of instability, which is dislocation. We have different size stems. This is a neck preserving stem. This works very well in the anterior approach. So this is, if someone's got very good bone, maybe some anatomy that makes it more difficult to get a stem in the right place, this one can be kind of altered in the angle. Here's our navigation in the hip. Don't have it all set up, but we have very similar technology. Put a couple pins. We have two little incisions on the other side to get know where the pelvis is. And then one of the other things that we've started to do is looking at the spine. We know that people who had spinal fusion are 8 times more likely to dislocate their hip. And a lot of patients have their hip and then get their spine fused. So we're kind of looking at people that have any spine problems. What's the orientation of the pelvis? How does it change when they sit to stand? So there's algorithms being developed for how to do this better. But it's something we're looking at. And that's my family and I in Jamaica. We've been going there, went there many years. And it's an old friend of ours, Jack, I met him 30 years ago when my wife and I didn't have kids. So, very quick. There's not many of you, so we can ask questions.
I have a question.
Sure.
I have had x-rays that show one knee is bone on bone,
Mm-hmm.
just barely,
Okay.
and the other's got a little bit of room left.
Mm-hmm.
But I don't actually have pain.
Okay.
I have, in some ways I move, I feel like my knee might buckle the wrong way.
Mm-hmm.
I guess the bottom line is, if it doesn't hurt, do you want to fix it?
So the short answer would be no, but you do want to follow it. So the indication for knee and hip replacement is, changes in your quality of life, not being able to do what you want it to do. So that usually is pain. Sometimes it's loss of motion. There are other things that happen, can be deformity. One of the things I showed you that x-ray, the different x-rays of the knee, the last knee x-ray, that person should have had surgery whether they have pain or not before they got to there. Because now they're in for a much bigger operation. You have to replace the bone that's been lost with metal, plastic, rods. You have to do basically a revision knee in a primary setting. That's not wise for anybody to choose. Almost always the pain will come at some point. It's interesting. We'll see people like yourself, maybe the one knee is bad, bone on bone, and the other one is almost there, but it's the one that bothers people the most. So there's just this time, and sometimes it's just happens. Sometimes there's a minor injury that triggers it. But people that have substantial arthritis, I try to follow them about once a year with an x-ray, just to kind of keep track of where it's going. But if it doesn't bother you that much, then you don't have to do anything about it yet. It will come, but it's interesting about when. Some people, it's much earlier in the course than others.
But if I follow it every year, there's no damage.
If there's no bone loss or no ligament damage, so sometimes the bone can hang in there, but we have enough deformity, you stretch ligaments, and then surgery becomes more complicated. That's also not good. So bone loss or stretching of ligaments that are necessary to balance a knee need to be assessed periodically. So it's good to see somebody like me, not just go to your family doctor if you're at that point. If you're not at that point, then it really doesn't matter. But once the bone starts to touch, it probably should be watched at least a couple times to kind of see what's happening.
Just one more quickie.
Sure.
What's the mechanism how does cortisone help?
It's an anti-inflammatory.
So is it mostly helping just to relieve the pain?
Correct. That's all it's for.
Okay.
There's no reason to do it. There's nothing that reverses this course. There's nothing that modifies this course. So there's no proof that any treatment at all changes the rate of progression of arthritis. So once the cartilage starts to be lost, how active you are is probably minimally impactful. So there's been some studies where they looked at thousands of patients that are highly sedentary, didn't walk outside their house, and people that walk for exercise, not marathon runners, but highly active people. And statistically, as a group, you couldn't see a difference in the rate of progression. So I do advise people to stay as active as they want to be, and that's kind of the goal. So what we do when we reconstruct joints is to get people back able to do things they want to do and remain active. So I think, that can sometimes just be a shot. We do a lot of that. Sometimes it's observation. We don't do a ton of that because most people that come to us don't come unless they have symptoms. And then it's surgery at some point for most people.
I don't want to take up everybody else's time, but the looseness that
instability. Yeah, that's some type of instability you're having. So that's a symptom that's more difficult to manage. So actually, therapy in and of itself doesn't do a lot for arthritis, but that's one place where therapy can be pretty helpful. So strengthening the muscles around the knee may alleviate that symptom. So going through enough therapy to understand what to do and then maintaining a regular strengthening of the muscles around the knee might benefit that.
So would one want to do knee bend kind of things? Or is that...
Well, you have to kind of individualize where the arthritis is, et cetera, but generally strengthening the quads and the hamstring without irritating the knee. And there are some ways to do that.
All right, I'll shut up.
Okay. Anybody else?
You had indicated that if you've got cartilage loss on one side of the knee,
right,
would there be an expectation that be progressive
So there is so there's an isolated type of part of knee arthritis called anteromedial DJD, which is medical terms, but it means the front inside of the knee. So if that's where the wear starts and the rest of the knee seems to be okay, if you address that, there's a window, if you address that with a partial knee replacement, it appears not to progress. I think if you ignore it, you eventually get to the point where that isn't a possibility. There's similar patterns of disease in the outside of the knee, although not quite as well defined, and there's similar patterns of disease in the kneecap. So we do see some people, probably the least common is pure kneecap disease. The rest of the knee is completely normal. There's partial knee replacement just for the kneecap area. Outside of the knee, also people do very well with that if they don't have disease elsewhere. But the disease on the inside of the knee is where the majority of partial knee replacements are done. That's where the majority of that pattern of disease exists. Partial knee replacements don't last quite as long in the literature. They aren't quite as durable as total knee replacement, but it's a smaller operation, shorter recovery period, and better patient satisfaction. So in the right patient, it's a very good procedure.
I've just been reading or hearing about technique involving fat, body fat.
So that would be stem cell.
Okay.
So I've actually had it
Yeah.
because one of my partners was learning to do it, and he needed some guinea pigs, and I volunteered because I got knee arthritis. I'm actually having my knee replaced one of these days in the near future. So I tried it. It didn't do much for end-stage arthritis. I don't think there's any data that shows stem cells are helping people with significant knee or hip arthritis. People are doing it. There's a lot of money involved, and insurance doesn't pay for it. I think that theoretically, stem cells may have a good role in certain injuries. Maybe if you have an ACL tear and you're going to damage your cartilage, maybe stem cells could help, ameliorate that process. Because we do know that people that have ACL tears, they basically all get arthritis eventually. It doesn't happen as quickly if you get your ACL reconstructed, but it still happens. Other questions? No? No? Not about a hip?
I'm very proficient in hips these days.
Okay. All right. Anything else? So, well, thanks for coming.
Thank you.
We'll keep your eye out for a new building. We